This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Our last speaker for the day, we're back to Dr. Martha Curley, and Martha is going to speak to us about the unique relationship between nurses and families in the PICU.
So when all else fails, there's always vodka. That's my mantra. We know that, right? It has to be the good vodka, though. So what I was asked to talk about was a little bit of the synergy model, but really talking about the relationships that we have with the families that we take care of. Now, Liz mentioned a couple times about how we have to find the passion, we have to find the enchantment, we have to be able to acknowledge the unique contributions that we make to the patients, and especially, I think, the families. And I have to say hello, Margaret. How are you? I haven't seen you for a while. I saw you early, and I almost was like, hey, Margaret, how are you? But anyway, so we talked a little bit about, before, what is it that we do? But I think nursing is really practiced within the relationships. If you think, at least from my perspective, the things that I remember, things that you remember in your career change over time. Initially in your career, you want to be able to make all the diagnosis of all the patients that you're taking care of and, be able to do it very, very well. But then once you've been there and you've done that a million times, how many meningococcemias can you deal with? How many of this can, one thing or another, ICP, all the stuff. You really take pause and you start looking at other things that really get you excited about what you do. And it really, for me, has always been about the families and how we get families through certain things. Now, all these families that you see on the bottom are families that significantly impacted my brain over time. The very first patient here, he was a lung transplant patient that we spent a lot of time with. It was one of the first lung transplants that we did in Boston. I was the clinical nurse specialist, so I had to figure out how to take care of these lung transplants. Alex never was survived off the operating room table. He came back down. He came back on ECMO. He could never get off ECMO, and he had a neurological death. But it was really about his mom. I loved Alex, but his mom, I still remember the time that I spent with his mom. This family here, this baby, you can't see, her name's Claire. She essentially was born with significant pulmonary hypoplasia. We orchestrated death off ECMO. So that couple, we talked about how to orchestrate death and how that was all going to, play out. Here's another patient. A lot of this was taking care as a clinical nurse specialist. You take care of the nurses in addition to the families, but he was a patient who had congenital diaphragmatic hernia and was with us for almost a year before he passed away. This was one of my very first moms I ever took care of. A long time ago, another infant with congenital diaphragmatic hernia who never came off ECMO. This is Chris. Chris had testicular cancer, didn't want to tell anybody about his lump, ended up with metastasis, so his whole family, we were with him for months. But, you remember the relationships that you have with these people. I have two sons. One is a sports writer. The other one, works with, I don't know what he does. What does he do? I'm looking, he does a lot of computer stuff and anyway, those two guys have to pay to get, they have to donate their time to feel the connectedness that they have. And we go to work every day and we feel connected and we make significant differences in the lives of families. I had both my sons volunteer for a while in high school Joe really resonated around taking care of people, but my other son was like, oh, I don't want to get in there. Oh, no way. I mean, he totally wasn't like that. But so there is differences, but I think what we do is we spend a lot of time with patients and families, and in pediatrics, it's all about taking care of the families. And if you don't resonate around families, you really can't, can't do it well. I did do a short stint as a nurse manager, and, when I'd say to people, so, why do you want to do pediatrics? And it's like, oh, I don't like taking care of adults. It'd be like, well, forget it, because all you do is you take care of adults. And so they totally didn't get a clue. But definitely within this, one of those things that we uniquely do as nurses is that we care for patients and families. And we take care of them within whatever bizarre nature their family is constituted with. We take care of them within that context. And so that's another hard thing that you no one really teaches you how to do that. You learn it by watching your colleagues do it, and those who do well. And I, really agree with you, Liz. I mean, in the units that I've always worked in, people fight to orchestrate death. I mean, they love that. It's not a burnout. It's a turn on, and which is kind of weird. But we don't go home and tell our families that. We kind of hold it and we share with each other, and definitely agree with you from that perspective. But definitely caring within families is a competency that is unique to pediatrics. The most disoriented I ever saw a group of nurses is when we had this horrific MVA where everybody was separated and the kids went one place and the parents went someplace else. And this kid arrived without anybody. He was neurologically brain dead. He was declared, and they were waiting for family to come in to orchestrate everything to be removed from the patient. And the nurses, because they didn't have anybody to take care of, were just kind of like walking into each other. And there wasn't anybody to take care of because the patient had obviously neurologically died, and there wasn't anybody else. And it was very disorienting because there wasn't anybody to take care of. So what I want to talk about just shortly is just our long history of caring really for families and our very short history of caring with families. And there's a difference here because we've spent a lot of time taking care of and not so much time partnering with them to do it together. And I think we're on a really dawn of a new generation of family-centered care. I want to talk a little bit about how we can develop some strategies that can enhance the partnerships that we have to develop with families. And again, think about how we can do this synergistically. So really, if you look at our history, and this is really Children's in Boston, they used to have cows, they used to milk for the babies in that building. But we used to just separate them. You got dropped off, and families would sit in the lobbies, if they were allowed to sit in the lobbies, and their kids would be removed for them. And then we knew that to be very, very bad. In fact, I just wrote an editorial for JAMA Pediatrics because they had a group of ID docs had written about how in the days of Ebola, we really just needed parents to not be with their children. That it was perfectly fine for care to be provided in this day and age with separation because we couldn't trust that families could understand how to do it, how to be a parent of a child with Ebola. So anyway, we wrote a flaming editorial. So it was accepted, so you'll get to read that. But we can't do this anymore. We just have to figure out how to make it happen, even when we're getting very bizarre situations, because we know the separation is not anything that we can do. And sometimes, this is a mom that I took care of. It was black and white. It was in probably the late 70s. This baby was beat up badly by this woman's partner. And sometimes it's really hard to take care of the families because you're like, how could you allow all of this stuff to happen? But it was every single family that comes in has stories that we just have to not judge, but just be with and just understand it, because it's hard to watch, but it's even harder, especially with some of the abusive situations, to be there and to nurse that family, but we're morally obligated to do that. So we separated, and then we had them come in, but they came in like this. We give them a chair, and then they sat. And then they watched everything that we did. But they were really kind of passive observers. But now I think we're really moving into Family-Centered Care 2015, where we welcome families in, and no matter what population you take care of, and including them as members of the team. Because, again, we know that we can take care of the kid, but if we don't take care of the family, it's not going to be, the child's going to go home with a family who doesn't know how to take care of them in pediatrics. But definitely partnering is very different, and including families in. Somebody just having finished up the Restore clinical trial, kids were more awake, and they were like, oh my God, what do you do with more awake kids? Well, you work with parents to help kids be more awake, and you know, there's a way here if we just partner differently with families. And the drivers for this, at least in the United States, are a whole bunch of governmental activities. Families are essential partners, and families are now seen as people who could be the gardener of quality and safety. So they can give us information that we simply don't have unless they're partnering with us. The Joint Commission says we have to show evidence that parents, families are partners at every level of care. They're now considered always events rather than never events, always events, so that, you know, every single day it's important for clinicians to perform, you know, care with families with that level of partnership that is occurring, and show, again, documentation of that. So it's now a quality indicator of care that families are there, they're present, and they're participating, not just being passive observant. So back in '87, we did articulate out what family-centered care was. You know, they're important, we support them, and that we're equals in partnership. But now I think we've got some legs going forward. The core values are exactly the same, again, being articulated a little bit differently, but respect, partnerships, anything that they choose to do, we support them in what they choose to do. But what we do is we give people, because they don't know how to parent a critically ill child, we give them some options, we educate them, and then we support them in anything that they want to do. And again, given the diversity of family, what might be perfectly acceptable for one set of family is totally not going to be acceptable for others. And this is a quote for Virginia Henderson. How many of you have read any of Virginia Henderson? You know, I loved her. She was on faculty at Yale. I loved her because she was shorter than me and fatter than me. And so anybody who's shorter and fatter is fine by me. But anyway, she would come around and, you know, but I mean, this is what she had said way back in '61. But, you know, what nurses do is rooted in the needs of humanity, okay? So what we do is essential for caring and compassion, but we're temporarily, and that's, again, temporarily, the conscious of the unconscious, the love of life for the suicidal, the leg of the amputee, the eyes of the newly blind, the means of locomotion for the infant, knowledge and confidence for the young mother, and the mouthpiece for those too weak or withdrawn to speak, and so on. So we temporarily engage in the relationship, strengthening the family's capacity, and then pull ourselves out of the relationship. And that's kind of the dance that we do. And it's hard to teach how to do that dance. The work that I did a long time ago had to do with getting to this outcome of mutuality. And those of you who are into Parsi and nurse theorists, which I totally wasn't at the time, but mutuality is about developing a relationship that's synchronous, co-constituting, that stimulates personal becoming. So what that means is that you engage with someone in doing a dance. Like you temporarily do things and then you let go and they pull them up. You co-constitute in that the parents are contributing something to their child. You're the nurse expert in that, but you have to partner together. The editorial that I responded to said, that parents can nurse their children. And I'm like, well, parents don't nurse their children. Maybe nurse like breastfeeding. But no, they're not nurses to their children. They're parents to their children. But we're the nurses. Okay, and we partner with them so that they can then become better parents of a kid that's critically ill. The personal becoming part has to do with the parents become competent as parent of a critically ill child, and the nurse becomes better mindful of themselves as a nurse. You learn how to be a better nurse having had those relationships that have been successful. And you watch people who couldn't do things, they were so blown away in even thinking about doing things. After you've taught them to do it, they're able to do it themselves. You derive a great deal of benefit, personal benefit, watching how you impacted a new mom, a new dad, a new family member take or assume responsibility for sometimes very horrendous situations. And even when, the kids don't survive, they feel supported. They feel as though, you've touched their lives in a way that no other discipline ever would, because you're 24/7 at the bedside. And you know them, and you're continuously formulating that relationship. So mutuality is a huge outcome variable for pediatric nursing. So we do all of these things, and it's very dependent upon the family. So it may be that you move somebody through just having a better understanding about themselves, get them to be competent, help them understand how to improve their health, their child's health, transitioning through just stressful event, and then definitely towards a peaceful death if that's what you're doing. Here are my boys when they were young and graduating, but the work that I had done with this was part of my master's thesis on helping develop or move towards that relationship. Anyway, which one is this one is a sports writer, this one I still don't know what the hell he does, something financial. But anyway, part of my master's thesis was how do you get to this relationship and how do you formulate the relationship? So I originally did the work, in New Haven, and then moved the work over to the nursing staff in Boston. I wanted to know if a nurse could establish a relationship with a family and then change those patients' outcomes, essentially decrease their stress. And then in this study, I wanted to know whether or not I could teach that to other nurses and it would decrease stress. So could you move it out? And you could. But the nursing mutual participation model of care was a model that essentially just treated people like human beings of value and of worth, asking them by using open-ended questions about what kind of issues they had, what were their goals and expectations, helping them learn what they needed to know in order to parent their child, and then ask them for suggestions. And when I first presented this, it would be like, no, duh. Are you kidding me? It's just like what you learn in kindergarten. It's just treating people with value and respect. And these were the questions that were developed at the time. Essentially, how are you doing? How does Johnny look to you today? What troubles you most? Here's some options that we can think about. How can I help you? And then how can we do this together? And if you just say to somebody, especially in the ICU when they're troubled by everything, and you say, what's troubling you most? It really forces them to prioritize what is really upsetting to them, so then you can help them. And sometimes by just saying, how can I help you? You know, they'll say either get out of here, get out of my face, or you can't help me, help my child. But then they'll always circle back and say, well, help me understand this, or help me do that. Or you can negotiate something to formulate at least some mutual benefit. And you're never, unless you're clairvoyant, you never know what the parents are thinking, except you just have to ask them. You know, what's troubling you most? How can I help you? What can we do together? So you go through the paces so that at least you have some sense of what they are experiencing. I once had this family who was for 3 days like this, just like staring me out for 3 days. I tried to be pleasant. I turned on all my charm, forget it. You know, no, they're just like this for 3 days. Finally, I said, you know, she warmed up after a while, and I finally said, why were you so angry for the last 3 days? And she said, angry? What are you talking about, angry? I wasn't angry. I was just trying to hold myself together. You know, so you don't know what's going on until you essentially ask them what's going on. And one approach with families will not work. You know, so when people say this is how I deal with all my families, well then, you know, they don't do well with families. Because some families want different types of relationships. They want different things from their nurses. And you just have to figure out what they want and then help them be successful in what they want, not necessarily what you want. And there is this dance, you know. So this is my bell curve here. But you know, it talks about who's leading the show and then what's the degree of interaction. But if they're a naive parent and they have no sense of what they need to know, you're pretty much directing in the beginning, doing lots of teaching, and then you're collaborating, and then you're just kind of pulled out again, and, you know, you're supporting. So you're doing the dance of meeting people where they are, giving them what they need, and then supporting them. And even if they're very experienced family, if they have a new phenomenon going on, they pop right back over here. So you have to always put them in context, but then address them according to the experience of what's happening. So it's adaptive. So, you know, again, with this patient who ends up not doing well, you know, as you gain experience taking care of families, originally it can be very stress-provoking because you feel as though they're staring at you, they're looking at you, they're judging, but they have no sense of, you know, knowing that unless they are their child's expert and if the patient's chronically, critically ill. But with time, as you get comfortable doing this, I do believe that families become essential to pediatric nursing practice and that it becomes a major source of both professional and personal satisfaction, which people will think, you know, as Liz indicated, you know, that families are burning, you know, they can burn us out. Yes, they can burn us out, but most of the time they're fueling us, you know, and if you allow yourself some engagement to get fueled, it ends up sustaining you and not necessarily burning you out. So it's really different, and I think of all the subspecialties in nursing, pediatric nurses got this nailed because we have to nail it. But really the outcomes characterized by this level of relationship fuels families and it fuels nursing. So we become more self-aware. It's not stressful but sustaining. You know, we become more competent with it. You know, families call us a wise, skillful, and compassionate stranger. In one qualitative study that I did, that's what a parent said that the nurse contributed. Wise, skillful, and compassionate stranger. And it's kind of interesting because we're so intimate while they're with us, and then when they go home, it's like we're a separate family. It's not, you know, and the boundary issues of going home and staying in are kind of interesting, but definitely satisfying. You know, we get to provide stellar care, witness personal growth on some of these families, and sometimes I think we created monsters. You know, and sometimes when the families they get so skillful taking care of their children that when they get a novice person in there, It's like they don't want to deal with the novice person because they can essentially do it themselves. But it's really this intimate relationship that you can share, this human connection that essentially no other discipline has. And so really the priority that I had talked about earlier is trying to build models of care delivery that will allow a synergistic relationship to form with families. And sometimes we are our own worst enemies because, you know, continuity of care being the way it is, we, you know, sometimes make decisions to pull teams apart when it's not really necessarily in the child's best interest. And, you know, I had the horrible experience being on the other side when my nephew decided to get high and dive into a pool with his girlfriend on his back and ended up being a high seat, you know, high quad. Was in the ICU at Massachusetts General Hospital for the summer, and vent dependent, and he was an ARDS. There was like questions of whether or not he should be cannulated for ECMO, and it was a horrible situation. But my sister-in-law, you know, you can't select your family sometimes. Anyway, my sister-in-law, she was having a hard time with it all, but I was trying to, you know, give her the words that she needed to negotiate his care, and she kept saying to me, every time I come in here, Tony's got a different nurse. And I said, well, did you ask the charge nurse why there's a different nurse? And then she goes, no, but I'm going to do that. I said, well, good, you know, so she made an appointment with the nurse manager to figure out why there was no continuity of care, and she was told that it was just so hard to take care of Tony. The nurses needed to be, you know, have their breaks, and that's what she was told. And at that point, it was like, to be a nurse and to hear that was just like gutting. You know, especially within your own family. And so then I had to work with her to try to find words to, you know, renegotiate that. There had to be some continuity. And with time, they got continuity, but she had to fight hard for it. So sometimes we're quite embarrassed by our own profession, but continuity of care, if you do, it's hard sometimes, especially with long-term hospitalizations, but you can develop a synergistic relationship with families. And the synergy model basically says that patients and families guide nursing practice, and when they come together in a synergistic, a mutually enhancing way, that you have better patient outcomes. So it's a stance of nursing where you base your practice on the needs of patients rather than what you think ought to happen. And so you allow patients and families always to take the lead, you know, unless they're going down a very bizarre road and you have to pull them back, okay? But in essence, if you never stray far from what's good for patients and families, you won't make a bad decision. Okay, so centering your practice on the needs of patients and families will mostly give you some really good outcomes. And, you know, part of the synergy model, there's multiple phases of it, but there's two big pieces as it relates to families. And what family characteristics come with is a very high to low capacity or ability to participate in decision-making and in care. So if you think on a scale of 0 to 10, you know, to what extent is this family participating in this child's care, and to what extent are they participating in decision-making, helps guide where you're going to interact with the family. So in doing that, you have to acknowledge that the care responsibilities change over time. What obligation you have as a parent of a newborn is very different than a parent of an adolescent, very different once you start having to be a caregiver, you know, to one's own parent. So developmentally things shift. And, you know, if I, as a parent of an adolescent, had to, you know, rethink of how to give my adolescent physical care and do physical things, it would have been very difficult because that's the stage of independence. You know, they don't want their mothers and fathers touching them. It's like, you know, get out of here. But if you're forced into that situation, it's difficult, even though it's still parenting. So you have to think about it from also a developmental perspective. And then definitely figure out from a participation in decision-making even from a cultural perspective, what's normed. You know, we were talking yesterday, Nick, about the, you know, the Maori culture and what's the norm of the culture, multi-culture, right? Did I say it right? Anyway, everyone has their own expectations, and so you have to figure out what it is, especially if you are responsible for taking care of them. But definitely, there's a whole host of competencies that families have come to expect for nurses, and what we need to do is kind of match what we do depending upon the needs of the family. So if the parent and the family are quiet, they're not necessarily participating in decision making, then our advocacy skills have to be fine-tuned, because we need to make that relationship work until they can find their place. Okay, so again, it's this dance of synergy within the relationship and trying to give patients and families what they need. So think about, as you're doing that, and what's most important in any particular family at any particular time changes over time. The measurement around families, again, if we're going to change how we interact with families, we need to get some really good metrics in the field. And, you know, we really don't have a lot of good metrics that really bring to life the relationships, the good relationships that we have with patients and families. If you look at satisfaction scales, it's like, you know, they showed up on time. You know, they gave us what we wanted, and they really don't measure the essence of the relationship. So some of the things that we measure around family-centered care, I think, can be improved. We can reframe it from a safety perspective. Because if we're teaching families to be the safety net, how are we measuring that? Time to critical intervention, hot new metric. What do we do in our relationships that allow us to detect changes over time and to intervene quickly? The better the relationship, the shorter the delta on time to critical intervention. So it's an important outcome. Family-centered care scale, I'll show you that in a second. How quickly do they move to appropriate self-care, and then can they demonstrate some health-promoting behavior? So here's a tool that we developed, and it really tried to get to the essence of mutuality. So the statements about the nurses help me feel welcomed. They help me feel important in my child's care. Valued team member. Give explanations for the nursing care they provide. Explain about changes that can be anticipated in my child's condition. Help my child feel well cared for, help me feel well cared for, okay? So those are the tagged questions, but we ask families, to what extent are these things important to you? And then we score it according to how consistently those things are provided. So if a family could care less about helping them feel important in their child's care, they're going to rate this not at all important. And to score well on here, you have to match it either to 1 or a 2, but not a 3, 4, 5, because you're providing care that's not matched to patient's need. So it's a novel way of trying to get to some of what pediatric nurses do and to score it. And how we score this is the percent match. The percent match of patients' expectations, families' expectations to what we give. So interesting metric. So I think in concluding here, we've seen an evolution. We've seen separation, we've seen passive observer, but now we're moving towards this engaged, okay, and that's the caveat, welcomed participant. So again, partnering with families in a way that they truly are members of the team. Participating, and you see here, in multidisciplinary rounds, giving information over time. So with that, I'll thank you, and hopefully we can have some good conversation. Thanks.